Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you, and we aim to take around 15 to 20 minutes. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. In this podcast, I talked to Dr Adam Popchak, who's a researcher at the University of Pittsburgh. He's been publishing some work on criterion for return to sport after injury. We discuss what clinicians need to know and the tests clinicians should do when making decisions regarding return to sport after shoulder injury. Hey, it's my great pleasure to welcome Adam Popchak to today's podcast. Adam, I'm really excited to have this discussion with you and talk about some of your recent research. So thanks for joining us.
Yeah, thank you as well. I'm really excited to join you and to discuss this stuff as well. So thank you very much for having me. I appreciate it.
Yeah, I'm really excited. I was just saying to Adam, we're obviously sharing some really common interests with some research that we're publishing. So it's really nice to, first of all, meet Adam and say hi, and also then get behind the scenes to see exactly what's going on in terms of why he's doing the types of things and see where the similarities and differences are. Adam, do you want to share your professional journey with us so far? Can you introduce yourself? How did you get to where you are? What are you currently doing work-wise? Where did all this start for you?
Yeah, so I'll try to give you the abbreviated version. So currently right now, I'm an associate professor at the University of Pittsburgh with appointments in the Department of Physical Therapy and in orthopedic surgery. But my kind of physio journey really starts back, initially was one of the, probably like many students at the time, thought I wanted to be strictly working with sports or a sports team, and that's where I wanted to be, and that's what I wanted to do. So I kind of, that was in my head. I graduated, and that's what my goal was. So after working for about 1.5 to 2 years in an outpatient orthopedic clinic or practice, I pursued an opportunity to do a sports physical therapy fellowship at the University of Pittsburgh Medical Center, or the Centers for Rehab Services. And that afforded me the opportunity to work both with like local amateur and professional teams in kind of the very kind of nuts and bolts sports setting. Mm-hmm. And during that time too, they also, as part of that program, there was a continuing education component to it where I did like basically a kind of an advanced master's sort of work specifically in rehabilitation and orthopedics. And what I thought was going to happen was I was going to absolutely love the sports setting, and that I was going to make those connections there and go into a life that way. And what I found out was that wasn't for me, but I absolutely loved the academic setting. And I really kind of got into the research side of things and to a certain extent, the teaching side of things as well. So kind of started to slowly bend my pathway to that. And fortunately, the continuing education coursework was able to kind of roll in to an early like PhD sort of stuff. So I was kind of partway there. So I continued working clinically for a couple of years while I finished that. So I kind of took a non-traditional route through into academia and into research. Mm-hmm. But eventually, along the way, had a ton of very significant, influential mentors along the way, mm-hmm. which I have to acknowledge their impact on kind of on my career and the career choice. But I was able to, when I completed that, get into a position of an assistant professor at the time and working on a few different research projects. And given my clinical background, I had connections with a lot of the local orthopedic surgeons because we had worked together from a clinical standpoint. So I still had the interest and love of like the sports and orthopedics. I had the connections with the surgeons, and now I had kind of the research methodology design sort of background. So I was, again, really fortunate to be in a system where there was a lot of collaborative kind of networks that take place and introduced, and working with people who can make more of those connections kind of work and foster different opportunities. So by saying yes to a lot of different projects, especially early on, probably more than I should have, it opened up more, more connections, more opportunities. And then was able to kind of really start to focus on what I was interested in, what my clinical questions were in terms of, returning patients to sports, that decision-making process and all the nuances that are associated and surrounding it. So I've always kind of had a background that I feel like I come at it from a very clinical perspective, because that's where I started. So, and that's where that's where everything kind of started from. So I think a lot of the work that we've been trying to do lately has really been especially aimed at, when I'm doing it more with the physical therapy sort of component of physiotherapy, is we have a lot of information, but how do we make this really clinically relevant for the people who are on the ground doing it? It's easy for us to sit in a research center and have one person there for 2 hours that we pay to be there to do tests. But when you have 4 patients and you have 20 minutes to do something, how does that correlate to what we're doing in a research setting? So I think trying to draw that connection has really been something that I've been most passionate about, and try to make what we're doing clinically relevant to the people who are doing it most frequently. So.
Yeah. And maybe that's what draws me to your work, because I think like it's great, like you say, is it's not difficult to pay for somebody to come for 2 hours, but actually what happens for the clinicians on the ground trying to make those decisions, how can we use the research to help them make those decisions and help the athletes make good decisions about whether they go back or not, or just trying to really make I think that is what draws me to your work, is the clinical relevance of it. I think that's probably where our similarities are.
Yeah, and exactly. I mean, if we're not doing, to me, I'm doing my part now to help the people who are in my position before, right? And we need to, they don't have the time or resources available to do it. That's now what we're trying to do, to give that and then those resources to be able to do it. So I feel like it's, again, kind of working in that collaborative sort of setting in space to be able to, kind of lend you my expertise and then hear you kind of take it from there. Exactly. So, so I think, again, I always really want to try to stay looping back to, all right, what's the clinical impact of what we're doing here? And if there isn't one, I maybe kind of shy away from that now at this point. I want there to be an impact on what we're doing. So.
Yeah. And I think that's what makes your work, meaningful, isn't it? And how you can help people. So you've published a number of papers on shoulder instability. Now that's what I wanted to really talk to you about today. This post-operative rehab paper that I've seen recently, your criteria for return to sport, and really how you think rehabilitation differs between anterior and posterior instability, what your thoughts are there. I don't know where you wanted to start. I guess maybe there's a recent paper you've published on recurrent instability and hyperlaxity, isn't there? That's do you want to steer us through the background for that, why you thought that was important, and how you went about that?
Yeah, because so that's mainly, again, from my work on a number of these trials, especially with the surgeons that I've been very fortunate to work with, the recurrent instability episodes, as soon as they start to deal with recurrence, things get a lot more complicated for all of us, right? So we're dealing with more bone loss, more extensive damage, possibly larger heel sacks, again, increasing the likelihood of further instability events. So, and then you throw in the hyperlaxity to it and how that further complicates things, right? So when you're dealing with that deficient static system, how do we kind of try to restore some of the stability from our aspect in terms of the things that we can do, not just surgically in terms of changing tissue, kind of extensibility and whatnot, but from our aspect in terms of strength, proprioception, kind of awareness, joint position awareness and whatnot. So we really kind of are looking, a lot at that, especially from the recurrent standpoint, and wanting to limit, obviously, as many recurrences as we can to, cut down on the post-traumatic osteoarthritis that occurs years down the road, or the severity of the overall injury. So, it's that kind of recurrent, avoiding the recurrences really that's been the biggest thing, it seems like, for us in terms of what we would consider successful too. So, and I'm not sure, what the trend has been there, but at least locally here they over the last probably 4 to 5 years, it's become much more likely that even after a first time dislocation, that they are kind of jumping on that and surgically stabilizing that if they're high risk right off the bat. Again, just kind of seeing that over the long term, they're probably seeing a little bit less overall kind of degeneration and issues that occur with that. So there's been now it's not fully adopted, but at least the people that I've been working with more recently, that they're kind of really taking that approach to being pretty aggressive with it overall.
And I think there's lots of interregional differences, aren't there? You know, like I think the current practice in New Zealand is not to operate, like generally, broadly speaking, you wouldn't be operated on a first-time dislocator. We know from some of my work that, you know, only 50% of them go on to have recurrence at 1 year follow-up. And so trying to work out who they are and who they're not. But I think that exists within different healthcare systems. I think healthcare systems are different across the world, obviously, aren't they? And so trying to extrapolate necessarily one country's data to another when the systems work differently, you know, I think that's really important that we appreciate that. There may not be one set way of dealing with people because you're operating obviously within an American system, and the system that I access here in New Zealand is very, you know, really what government subsidies for traumatic injuries with early access to therapy and rehab, and you know, so they're just different, aren't they? But I think that
that definitely plays a part. The one thing though, you did say, you know, only 50% are likely to reoccur within 1 year. You say only, that's still a pretty high percentage, but you know,
but
it's not everyone, right? It's those ones that are at high risk, right? That 16-year-old, 17-year-old collision sport athlete, you know, that it's like at their highest risk. Those ones are the ones that they're pretty much, the paradigm has kind of shifted, at least here, in terms of how they're addressing that initially.
So interesting, isn't it? This isn't what I wanted to talk to you about, but it's so interesting because we know that from some research that then surgery fails for half of those people. Do you know? So it's just an interesting, I guess, and that's where I think collaborating in the role that you're in is trying to blend both of those together. So perhaps if you work, because we also know that recurrence is high in those people, you know, under the age of 25, it's more than your rate increases, doesn't it? So if there's a way to collaborate so that your surgery then was more successful and wasn't failing for 50% of people, then because we also know that the surgery increases the risk of arthritis. So trying to find, it's such a conundrum, isn't it? And trying to navigate our way through this is, I think, is really important.
It is. So our we have an ongoing multi-center trial here. It's called the OASIS trial that we are, again, working with a group of orthopedic surgeons and then the associated PT, and where they're looking at, you know, 3 different surgical kind of options or treatment for people with specifically anterior instability in the setting of subcritical glenoid bone loss. So about 10 to 20% glenoid bone loss. And then we're following them as extensively as we can for 2 years through rehabilitation, through different testing assessments over a 2-year period of time, really with the goal of seeing, okay, you know, one, is there a superior surgical option? But, you know, from our perspective as rehab professionals, are there modifiable features or signs or anything that we're seeing along the way that is predictive of either successful return to pre-injury activities or unsuccessful? And then really trying to see, all right, if we're able to identify this, how do we then kind of modify this and how do we improve this? So, you know, and that's really with that trial, we're hoping that, you know, as we collect more patients and more data, that we start to see not only surgical, but also post-operative key factors at different time points that we can really try to address. That makes the overall, you know, makes it overall more successful. It's always hard though, like running a trial, as you know, and getting, you know, as many people to volunteer, to consent to do it and whatnot. So, you know, it's going to, unfortunately, from the conception of the idea to the actual conclusion and the results and summary can be a really long period of time, right? So we're in that slog right now, but, you know, hopefully at some point here in the next few years, we have maybe some answers to those questions. Like, hey, these are some of the important features that are showing up maybe at 3 months or at 6 months. And
Do you have any
the
thoughts, just like any indications or any hypothesis yourself at the minute of what that might
well,
be?
just based on some previous work, at least from, from the kind of the post-operative side, there's just that residual weakness that's present in particular in the posterior cuff. So if you really test people, pretty specifically with either isokinetics or some form of standardized approach, you're probably going to see a residual weakness in the posterior cuff, which I think probably factors in
Okay.
To some extent, where they may be performing fairly well in their functional tests. They figured out a way to compensate for it, but when you really isolate down in, you still see the weakness there. So I think that might be a factor. And the other thing, and not to sound like I'm not very hopeful or anything, but I think to a certain extent, there's just an exposure issue too. It's a highly susceptible joint, even when it's fully rehabbed and at its optimal performance. Some of these sports are just really high risk, and there's a certain extent, I think I want to say have to accept it, but there's just a certain risk level that's present where, even if everything is optimal, it still might occur, right? Just due to the forces and the loads and the positions that are placed on it. So, but really, I think the weakness, and then what we haven't really figured out is again, going back to what we were saying before in terms of making things clinically relevant, is a good way to really assess proprioception, joint positions, sensitive, those types of things. We can easily assess, they have enough motion, they have enough strength, their ratios are good, but we don't really know how they're perceiving that joint in terms of stability. And that's something we've kind of struggled with here, trying to think of different ways that we can make something clinically relevant, because, we're not, again, a clinician's not going to be able to find a biodex and put someone on there and proprioceptive protocol or something like that.
And even within that, isn't it? It's like from what I understand of the research is, 1 to 2 degrees, or at best a bit more than that. Really difficult to measure that in the clinic, because of the variance.
So, and I think that has I think that plays my suspicion is that plays a factor in what occurs, right? How well are these people controlling their shoulder or their position, right? But if that's something that's really hard for us to not only assess, but then how do we optimally train it as well, right?
Still lots of questions in that space.
So, and then there's the psychological stuff too.
And I'm becoming more and more interested in that recently.
Which, again, the more you look at it, the more you realize, like, there's a boatload of issues here with this, right? And this is something that's probably very impactful. So again, really multifaceted, which I think which creates the clinical complexity to it, right? It's not very straightforward at all. So
and so I guess so we stay in thinking about getting people back to sport, because you've done some other criterion based research, and I think specifically in posterior instability. Do you want to tell us?
So we started in anterior instability with it, and then we did a follow-up using the same assessment methods, and they were pretty standard from what most people would probably be using in terms of doing isometric and isokinetic strength testing for internal and external rotation, looking at side-to-side differences. We used an endurance test for the external rotators in side lying and prone at 90. The closed kinetic chain.
The posterior endurance test from
well, a version, not that one exactly, but essentially a repetition to failure for pure external rotation. We did that a little bit before that. The endurance test was kind of out, so we didn't have that when we started doing. Closed kinetic upper extremity stability test, and then a seated shot put test. So that was the group that we used. And initially, when we did it with people, and then we followed them. We didn't really follow them. We went back and retrospectively collected the information a couple years afterwards, and we're able to look and see, and the deficits there that were present. I got somewhat of an idea of return to sport, although again, without collecting it prospectively, I don't know how good of a, how representative that was. So we then kind of repeated the same procedures, but this time looked at people who just had posterior repairs. And it was not nearly as able to differentiate between people who were successful and who weren't. So it's possible the procedures we used maybe weren't specific enough to the deficits that might be present with posterior instability. It may have just been kind of small and underpowered, so there's a
number
we
of
probably
factors.
need to look at it more closely, but it was not nearly as predictive as it was with the anterior instability, which I thought was interesting.
It's interesting, isn't it? Because some of these things, I worry about some of these tests that aren't putting people in provocative positions, so we have this closed kinetic chain test, and we know that that's loading the posterior cuff, don't we, serratus anterior, working really hard in that position, but still in a position of flexion that's provocative for somebody with posterior instability, but not necessarily anterior instability. I think that's where one of the gaps are in our clinical testing right now, isn't it? Where like it's all those upper quarter Y things again, still loading in that flexed at 90 position, which I think is provocative for posterior instability, sure, but we need. Do you think we need something else in this space, or we have enough that we could extrapolate? We just haven't done the work yet, or what are your thoughts?
I think we maybe need something a little bit more specific. And I know, and I was just looking at some of your recent work. I saw that you were a co-investigator, collaborator with Dr. Rubin on the dynamic anterior shoulder instability test. And if it's the same one that I've spoken with him in the past about, I think that kind of gets into that position of moving through that external rotation. Again, kind of getting back to being fortunately having made a lot of good connections over the years. I think that's, something that holds a lot of potential, right? Because it's putting people right into the specific position. It's more dynamic in nature. It's reproducing, the exact kind of position they need to be in. So yes, I think there's probably a way to be more specific with it.
The problem I think with that test perhaps is maybe like it's a repetition type thing. How many can you do type thing? I was surprised the number of people who were quite provocative then at end range flexion, and now I look for that clinically. You're painful or stiff at end range flexion, and do you then change with an AP glide in the clinic? That's now what I look for on the back of that test. I was surprised how provocative it was in that space. We talk about this 90-90 being out at 135, but actually end range flexion turned out to be quite a problem as well.
It's something we never really probably expected or thought of. So I think something that kind of more directly gets at it. And then I always kind of wonder too, does there need to be something that's as sport specific as possible? Does there need to be some sort of test assessment that is as closely replicates what they're going to be doing as you possibly can, right? So the only problem with that is then you start to lose the reliability, responsiveness, validity sort of and whatnot. So now you're kind of winging it, trying to make up something that's not really probably reproducible. But to a certain extent, I kind of think there probably needs to be either from an assessment standpoint or at least from a gradual exposure standpoint where they are.
That gives you that progressive exposure, doesn't it? Because that seems to change your confidence and decrease your fear to, all those sorts of things. Is quite a lot tied into that. I think that's the discussions I've been having with Tim All is around, reproducing direction of force, position of the arm, does it need to be sport specific or injury specific, or perhaps a combination of both? I think that's where it differs a bit from ACL, return to play, doesn't it? Is for me, like you can cut and move so many ways.
But are you throwing, or are you hitting a ball, are you striking, a volleyball, or are you wrestling someone? Those are, extremely different demands that are being placed across there. So, but I fully kind of really agree with the gradual exposure, the increasing confidence, and really I think that is one of the main things we do. as a rehab specialist is,
Yeah.
kind of knowing when to say, yeah, you can start doing this and this is how you're going to do it. Right. And starting to show patients that, oh, okay, yeah, you can do this. And all right, let's take the next step. So
Yeah.
I feel like that's one of the main things that we can do. Yes, I want to say it's easy to just kind of deliver a strength and loading protocol and whatnot, but it's that timing and exposure kind of that I think where we really help them out the most in terms
Yeah.
of kind of saying, what's important about rehab.
Yeah.
I think
Yeah.
it's
Yeah.
really one of the most important things about rehab is kind of guiding them through when they're okay, when that they're okay to do something and exposing them to that so they can start to develop that confidence in their own abilities.
And what are your thoughts regarding testing for, sort of return to play versus return to performance, or, because a lot of the tests that I've been thinking about using is really clearing from physical therapy to move back into like a more of a training space. What are your thoughts around those different levels of return to play? What do you think?
Again, I think some of it is based on, kind of where you practice and where we're at in the paradigm you practice, but I'm probably more with you in terms of when we're looking at it, I'm looking at it from the perspective, and I think our research has mainly been, all right, can we release you from essentially physical therapy, from formal care back to the team, right? And then from there, the team and whoever, hopefully there's a specialist there, they're going to take you through, unopposed individual drills to light opposed drills and integrate you in that way. Unfortunately, I think most of us in our practice settings can't assist with that, right? They're no longer with us to guide that sort of process. So I think unfortunately, at least in many of the settings here, we're limited with when we lose touch with them, right? And when we lose contact with them.
And maybe there's ways to guide people through that, without that personal contact. This is then the expectations. And I think that's what's probably important for clinicians to remember, isn't it? They may discharge them from their care, but there's still layers of their rehabilitation, shall we call that need to be progressed, like you say, unopposed drills, then opposed drills, and opposed restricted versus full contact. Those sorts of layers are what we would expect, I guess. And then I've been interested in that psychological element of that, like of doing that with somebody coming at you or not coming at you, those sorts of things to think about.
Adding again the psychological aspect, adding the distraction aspect, adding, all of that. Again, it's extremely difficult, I think, for us to recreate that in a clinical setting, right? So,
my little clinic room,
but that's, so that's the hard part. But so from our criteria and return to sport sort of testing standpoint, I think it's probably a little bit more return to team activities as it is purely a return to competitive sports, right? So that's at least more my take and perspective on it, because I don't think we're necessarily able to totally challenge them as closely as they need to be in a competitive 100% sort of environment. And until they can work through that, my assumption would be they're a little bit probably not prepared, right? Or might be a little bit higher risk than they should be when they fully return.
So a bit underdone, eh?
Mm-hmm.
Can you there's some other, so I guess now I'm thinking about these clusters of tests that we use, how we talked about, we know that some tests have got quite high correlations. I think in one of your papers I read about external rotation and shot put, and we're trying to make things then meaningful. If they've got a high correlation, are they measuring the same construct? Do we need to be putting together a battery of tests that measure different constructs, and so that we in a time poor environment, how do we deliver something that captures all those different range of movement and strength and time to peak torque perhaps and proprioception? What are your thoughts about constructs and how that might be different for different injuries?
That's a great question. And I think again, strictly from a academic research world, like we love to see all right, these correlate, these are valid, these are correlate. But you're right. If they're essentially measuring a similar domain, do we need to be duplicative about it, right? So whether they're measuring the same, at least for the external rotation strength and the shot put, whether they're measuring the same domain or not, I'm not certain. I think intuitively I would say, well, they're correlated, so they're obviously connected.
Yes.
But is it a one-to-one connection, or are
there other modulators there? Because I looked at it and I thought,
and that strength is kind of component of the power that you have with the shot put. So I'm not exactly sure, but I do fully agree from the standpoint of whatever we decide to do or whatever somebody is going to do needs to be as concise and clear and repeatable as possible. Because if it's not, one, you're not gonna have time to do it.
Yeah.
And then you're not gonna do it, right? And two, if you have too much going on, sometimes it's what information do you use, right? You can almost be drowned in.
There's a fatigue component, because
Exactly.
like I say, I put together those SARTs battery of tests, and then you really have to be careful about which ones you use and the order you do them in, because some of them they're pretty tough. Do you know? Your athlete is really tired and you continually do that, then they're failing the last one, and so that's not particularly helpful. In terms of just some advice for clinicians putting together a return to sport test battery, what constructs do you think are important for them?
So from a constructs perspective, I would say there probably has to be some sort of strength component, some sort of functional component, a psychological assessment or confidence assessment of some sort. Those to me are the primary ones. Obviously they need to have full or relatively full range of motion to even kind of get into that. So I don't necessarily consider that part of like the normal constructs, because I think most people look at it, if they're restricted in that, then they're really probably not going to be doing these higher level activities. And then from the functional testing standpoint, things that either are reliable, responsive, valid, but as closely match their demands as possible is what I would kind of say, right? So we know that some are really good, but if it's not really putting them in anywhere near the position or activity of what they're doing, how useful is that information for you? So in terms of their specific sort of activity. And then, I would say whatever you decide to do, like make that your little data set that you collect, and then try to do it as frequently or, as consistently as possible. And then maybe you start to see, this is telling me something. I think this is telling me something. Maybe I don't think this is telling me anything. And maybe you switch, right? But I think without that repetition and that incoming sort of information where you can kind of see what it's telling you, and is it matching up? Not only are the numbers actually matching up with what you see, and you can tell this performance, right? So I think and that's something too, it's really hard to assess, like how do we qualitatively, what do our eyes tell us, right? We're experts in watching people move. So we can't kind of just completely forget about the qualitative aspect of things too, right? So
and you think that repetition is important between athletes or within athlete across time? What do I get an understanding that you mean that the clinician would get more experience at doing it and therefore be able to see what those numbers mean across all their different athletes? Or so
I was thinking more like that across different people, just like find what your set of these are the parameters I'm going to look at, and I'm going to look at it, everyone who approaches this point, and then maybe from that you start to see things that are more valuable from you. But I think at least doing something consistently and defined keeps you kind of on track, as opposed to pulling different things all the time, and then you don't really have a comparison basis at that point, right? At least doing it kind of where you're using the same things, you have this thought of, okay, I've seen now this people who have been successful did really well here, or they looked really good here. And people who I wasn't quite sure about, they didn't look great, so maybe you start to see some trends that kind of show up.
And that's what we've done here in the clinic, actually, is look at, overhead swimming athletes. They have a protocol that we run through to look for that looks like strength and range of movement, and then specific testing, and then the posterior instabilities, and then the anterior instabilities are different as well. So good to hear that you think we're on the right track by carrying on.
I completely agree with that. And then, the last thing that I would say about in terms of that from a clinical aspect, and probably the hardest thing, is trying to somehow get outcomes information, right? And I know we lose track of people, and it's hard to, especially in this group, right? We're talking about 16 to 25-year-old men who are transient and don't like, who are all over the place. But, yes, it's great to have that information, but unless we really know ultimately how they do, it's hard for us to really totally get an assessment of where it's at. So somehow being able to track that. And again, that's something, if someone has a great way of doing that, like that's kind of the, I think the last key component. And
looking at that predictive validity, trying to understand, okay, so this might be important with limb symmetry, but what does that mean then in terms of actual prediction or actual outcome?
Did they get back to where they wanted to be? Did they, do they have a 90, 100% on their WOC score or something like that? But again, it's hard to get that a year later, 2 years later, to kind of see where they're at, right?
In this mobile population, I mean, they seem to be the same, that 16 to 25, I think they change their mobile numbers perhaps more than they move addresses. Like, difficult to track them down, I guess, is what we've found.
Same here. It's very difficult, and it's even when you tell them, listen, we're going to be following you, you're going to be getting emails or text messages or something for the next 2 years. It's really hard keeping track of, or getting responses from probably more than 30% of them or so over that period of time. So it's just really hard to get them.
I don't have, and what do we acknowledge the difficulties there, like some of this stuff is very difficult to study because of patients. I guess there's one more thing I wanted to talk to you about, really, and it sort of centers around glenoid tract, and it sort of takes us back to that first paper. Can you talk to us, for those people, maybe talk to people about glenoid tract and just let people know what that is, and then what your thoughts are around that and instability, because I think there's some interesting work coming out here,
Yeah. So again, something that generally I haven't necessarily been the lead on by any specific aspect, but kind of been a part of a number of different papers. And so the glenoid tract, in terms of just trying to summarize it as quickly as I can, especially with the anterior dislocations, right? We get the potential impaction of the posterior humeral head onto the anterior glenoid, which creates the glenoid or the Hill-Sachs lesion. And then we could also have a deterioration or a loss of that anterior portion of the glenoid bone. So the glenoid tract, just in general, when we move, essentially the humeral head is going to cover about 83%, I believe, of the glenoid. But when there's now losses in bone of either any portion of the glenoid, or you have a substantial, significant Hill-Sachs lesion, as you're going through that rotation and it's moving on the glenoid, there's a higher likelihood that Hill-Sachs lesion is going to engage a portion of that glenoid rim, right? And when that engages, that's going to increase the likelihood of recurrent instability events. So what they've really seen was with just strictly an arthroscopic Bankart repair, which is probably 70% or so of the procedures that are done initially. If it's off track, meaning that the humeral head is not staying on there, it's riding off and potentially engaging that Hill-Sachs lesion, there either needs to be some sort of bony augmentation or like a remplissage to fill in the Hill-Sachs lesion. So I think, again, from my understanding, that was initially really looked at as kind of binary. Are they on track, off track? Again, some of the surgeons I worked with here have done some work where they're looking at less as a binary on or off and more as a continuum, and seeing that that's actually a lot more predictive too, right? So even people who were on track, but they were close to being off track.
The old near track. I had.
Exactly. So this whole concept of a near track lesion as well is becoming a little bit more apparent. Right. And it makes sense, right? Things aren't black or white and kind of very binary like this. So, but so it's kind of, I think, starting to take shape more into that near track sort of area and looking to see. And then that's going to really, again, to my understanding, inform them on what surgical procedures they need to do. I'm not quite sure of the impact it has on us, from the post-operative standpoint, other than maybe if there's certain tissue that they've had to disrupt or we need to protect for a period of time afterwards. But again, from our discussions, know that in their world, that those are modifiable features that are going to lead to either recurrent or outcome or whatnot. So I think it goes hand in hand with what we're doing. But that concept is, I think, becoming a little bit more clear over time as they start to investigate that a little bit.
Yeah. It's really interesting, isn't it? I think I don't want to keep you too long, Adam, but do you think what do you think from the work you've done so far and the work you're currently doing, what are the key clinical takeaways that you want clinicians to know? Like, what do you think is important that they understand about what you've done with your work and what you're currently investigating? What do you think?
Well, I think like some of the things we said, selecting something that makes sense to you and doing it repeatedly, right? To kind of start to make your own value assessments and your own judgments. We really don't have in our community, we really don't have a single best way to do this at this point. So we can't say, this is the way that's really recommended. There's a lot of different kind of protocols out there and whatnot. So I think clinicians would need to find what works for them, and realizing that everyone has a different set of assets. They have different time, they have different equipment and whatnot. So what works for you? And try to do that repeatedly, try to do that as consistently as you can. Would probably be my main thing. And then keep your self open to having your mind changed, essentially. So, and seeing where the information takes you, right? So thinking that you maybe have an idea, but being very open to being wrong with that, and having having different information shape your opinion on which direction you should go.
I guess addressing your clinical bias, because I think there's a lot of information coming out maybe in the next 5 to 10 years, and how do we start to use that, and how can we shape that information so that it's our athletes and our patients do better. So it's cool.
So I would say that's probably the biggest thing. Be open to to change, right, and to different information, and then value the input that your patient's giving you, right? They probably know themselves better than any other. So if we're not kind of asking for their substantial, significant sort of input, right, I think we're missing out on it a little bit, right? So sometimes it might be as simple as saying, what do we need to do? What do we need to work on? Or what are you not comfortable with? And then kind of starting to address that, right? So basically I'm saying being kind of humble, not thinking you have the plan, right? And being open to
completely. And I think that's what I've learned about some of the psychological stuff that I've been looking at, like, as a medical community, we've been asking about recurrence, and we're still measuring recurrence, but actually some people aren't particularly bothered by recurrence. They're bothered by the impact. And so now I routinely ask, how does this affect you? Because and if you're not affected, then, but if you are, then that's something we need to drill into, So
I think, just that shared kind of decision-making and realizing this is a very team sort of approach, right, with everything is probably the biggest thing. And I completely agree with you. We need to know where they're at and what they're thinking, right, to best help them. So asking those questions and making sure that we're getting those answers, I think is
yes, and being open when perhaps the answers aren't what we particularly want to hear. I guess from you, isn't it?
Absolutely.
Hey, well, thanks very much for your time. It's been fascinating to talk to you and hear what you're up to, and like I say, the similarities and the differences and what we can learn from each other, I guess, to move this
absolutely
forward.
Thank you so much too, and I really appreciate talking to you. It's been a pleasure, and hopefully we can work together on something at some point too. So I'm always open to sharing ideas and working on projects with people and stuff, and realizing that I learn more from being around as many different people and opinions and the viewpoints as possible. So hopefully we can do that again in the future.
I look forward to it. Thanks.
All right, awesome. Thank you so much. Take care. Bye.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.